Hey, who wants to start off with this one?
Okay, I can go with that one. So we have a shape biopsy of what appears to be a papule, and there are two interesting features. The epidermis looks normal. In the dermis, there is a collection of a bluish hued material, and also there is um, like Swiss cheese appearance
Yeah.
of what first I thought looked like some sort of gland, like glandular spaces, or but then I thought the bluish thing is hyaluronic acid, and the other reminded me it didn't really look like dots in all the areas, and I wasn't sure if they were dots or another filler, which is something that you see sometimes.
Yeah. Notice how each one of those little holes is pretty much very homogeneous. They all
Yeah,
look kind of about the same. I
yeah,
think that's kind of important.
yeah.
Because
I
if
thought,
this were like something that happened inside the body, there'd probably be a lot more variability. These
yeah,
look like they probably were manufactured in some sort of a plant.
silicone.
So, yeah.
Yeah, I thought it was silicone and or paraffin or whatever this person got injected into this area.
Well, silicon generally gives you what looks like little sort of Swiss cheese tiny bubbles. These are almost like little sort of BBs in a way. I think this is a different filler
Or
than that. And
PRI.
there's something, you see some residual stuff. Most of it got washed out. I think this probably had two fillers. So you're right. This is the hyaluronic acid filler. It looks like sort of bluish gray jello in the skin. That's hyaluronic acid. But these others, radius, calcium hydroxyl so those you'll see calcified little areas there, kind of grayish blue beads. But I think there's a couple others that are round, small aggregations that they inject also that look like this too. And the PowerPoint, I think this PowerPoint doesn't have it, but the one I gave to the lecture there did have it. So there are other things like this, maybe that polyacrylamide gel or something like that. But there's several other fillers that give you little round dots. Radius is the one that you use for patients with HIV infection that's permanent, and that's got calcium in it. And you can see there are histiocytes here.
Yeah.
And even some plasma cells. So this is an inflammatory reaction. Silicone generally has, you can see the little tiny droplets. So I don't think this is silicone. I think it's another filler. And you can see it does have some histiocytic reaction to it. So this is one of the filler reactions. The boards like to ask about these, so I would recommend boning up on what these are, which filler contains what chemicals, because they like to ask that sort of stuff on the exam.
Silicone is sometimes different sizes, right?
Yes,
the bubbles.
You get little teensy tiny bubbles, not these sort of large droplets like you see here. So I really do not favor silicone. But if somebody is a cosmetically oriented patient, they want everything. They want fat injections, they want hyaluronic acid, they want Botox, they want dermabrasion, they want the whole ball game. So a lot of these people get multiple fillers, just loaded up with all sorts of wonderful things. Okay. All right. That's a nice, cute little one to do.
Alright, so we're looking at a shave biopsy. Sorry. A shave biopsy. I'm getting, if I can focus, sorry. So we see these collections, like these kind of foamy collections, cells of
Yeah,
foamy
they have
cells
clear
here.
staining cytoplasm. Good. So you think it's a neoplasm, right?
Yes.
And you think it's benign or malignant?
I think this one's benign.
Yeah, very much benign, very symmetrical. And epithelial or non-epithelial?
Non-epithelial. Like more of like a glandular.
Now, is glands, is that an epithelium?
Oh, yes.
Yeah, so it is. It's not squamous epithelium, but it is glandular epithelium. So which kind of gland are we looking at here?
The sebaceous.
Sebaceous gland.
You can see from
Very good.
far out the foaminess.
Yeah, so it's got a lot of clear staining cytoplasm because it has lipid in the cytoplasm. Okay.
So that this one was a sebaceous adenoma.
Yeah, sebaceous adenoma. Now, what's in the differential of this?
You like sebaceous epithelioma?
And what is that?
That has like over 50% baseloid cells.
Yeah, you know,
Usually
sebaceous
that's kind of-
epithelioma is not a term that we use quite as much as used to be used in the old days, because that actually, epithelioma is the French word for cancer, for carcinoma. So generally, if you say sebaceous epithelioma, you're really almost kind of saying sebaceous carcinoma, which clearly it's not. So sebaceoma is the other term we'll use. Sometimes if we're not 100% sure, we may say sebaceous epithelioma with atypicality. It's a hedge crummy diagnosis, but that does have more of the basaloid germinative cells. And sebaceoma also has that. And then the other thing about this, what about the architecture of this?
So it's pretty symmetrical.
It is, but what about the shape of it?
So it's, it's like slightly nodular.
Well, sort of cup-shaped, isn't it?
Cup-shaped, yeah.
Yeah, it's kind of got a cup-shaped architecture, and that favors sebaceous adenoma also. And the only thing in the differential would be sebaceous hyperplasia. Just garden variety, normal appearing sebaceous glands that are just too many per unit area. You can see that this does have more of the basaloid germinative cells. You don't really see that in sebaceous hyperplasia. So this is truly a hamartomatous lesion. Now, is there any concern about this thing that you have to be worried about?
Not necessarily, but you should think about a patient that might have Murray-Turry syndrome.
Yeah, Murray-Turry syndrome.
Murray-Turry syndrome.
Yep. And so if they just had one, would you worry about Murray-Turry? Or
No, I think
probably
like
not.
2 or
But
3 or more.
yeah, generally they want to have multiple ones. You can also look for microsatellite instability here.
Like the loss of MSH2 or
Yeah, there's
LH1.
4 of them we look for: MLH1, MSH2 and 6, and PMS2. So there's 4 of these that you can look for. So there are immunoperoxidase stains that you can do, and you look for a diminished number of these. This is kind of what they look like, just sort of large, giant sebaceous hyperplasia lesions, like on the forehead there. So again, this is just a benign sebaceous adenoma. Good. So everybody needs to make sure you know that, and make sure you know the Murray-Turry syndrome. Okay. Let's give this one a go.
Okay, so we have a shape biopsy. And the changes are pretty subtle. It's kind of in the epidermis, kind of in the central area of the biopsy. You could see from this low power view that there's something happening. I don't know if it's like, from here it looks like it could be parakeratosis or something.
Yeah, there's a little bit of
there.
abnormal cornified material here, and then there's kind of
Then there's
clear there, isn't it?
Acanthosis, and maybe some sort of changes in the dermal junction area.
Yeah, so what kind of change are we looking at here?
It looks, from this view, vacuolization.
Yeah, there are little holes here, but if you notice, the cells sort of seem to be falling apart. So there's some desmosomes, and you see they're trying to keep these cells together here. It's doing its best to keep them from pulling apart. It's like, hey, don't leave. You don't want you to go away here.
Acantholytic cells.
Acantholysis, right. And then this area, you said it was parakeratosis. There's a little bit of that. But what's going on up in this area?
Maybe some dyskeratosis.
Yeah. So what's the histologic reaction pattern here? You've
So
already
there's
said it.
dyskeratosis, acantholysis.
Yeah, focal acantholytic dyskeratosis, FAD. And what's the most common setting where we see that?
If it's focal, then you think more like Grover's.
Grover's is by far the most common situation where we see this. So this is Grover's disease. Now, what else do you have to think about?
You could think of like Darier's.
You could think of Darier's.
But that would be more less focal. More
Yeah,
less.
exactly. Usually you'll see several different foci in the same biopsy of Derriers. I mean, it could still be Derriers. They just maybe sampled one little tiny papule, but yeah, I would favor Grover's in something like this. Also, Grover's generally does not tend to involve the hair follicle. In general, when you get things like pemphigus or any of those acantholytic disorders, they're real. They're not just kind of acantholytic dyskeratotic histologic reaction patterns, or it's not Grover's. They don't tend to involve the follicle, certainly not the deep part of the follicle. So that's a clue that will help you. Any other diseases that give you FAD?
I mean, Haley's more,
Yeah, it's not as much of that. It's more just kind of diffuse acantholysis there. Because sometimes you get a little bit of dyskeratosis, but not a lot. There's a couple other diseases, though, that you need to know.
can viral changes?
Not usually. No, that wouldn't. We're talking about if it's true focal acantholytic dyskeratosis. So Derriers, Grover's, there's about 4 others that you should know about.
40D.
40 dyskeratoma, good.
There's a weird follicular. I always
Yeah,
forget
familial dyskeratotic comedones. Yep, that's another one that you can get it in. There's a couple others. Sometimes you'll just see one lesion you biopsy and shows FAD, just solitary acantholytic keratosis. Solitary keratosis. Sometimes you'll see that. And sometimes you get linear epidermal nevi, linear Derriers, segmental Derriers that has the same change. So you have to know the reaction pattern. So this is Grover's. Nice example of it right here. Sometimes we see Grover's in younger women. So it's not always seen in men for some reason. So anyway, just make sure you know all of these. Now, what are the other histologic reaction patterns of Grover's? So one is FAD. There's a few others here that you have to know about in Grover's.
I think one is spongiotic.
Yep, you get spongiosis. What else?
So spongiotic, yeah, cantolytic, and then I don't know now the other two.
There's Haley type.
Okay.
There's superficial pemphigus type, and then there's pemphigus vulgaris type. And sometimes you can see epidermolytic hyperkeratosis. Recently reported that a patient with classic Grover's who biopsied and showed epidermolytic hyperkeratosis. So make sure you know those also. Okay. And then it's been associated with certain drugs. I'm not sure I believe that. I think they probably are older guys that are taking those meds and have Grover's and they're on those drugs. Say, another case report. So pad my CD a little bit. Say it's associated with med. So probably not. Okay, what about this?
All right, here we have a punch biopsy in the deeper dermis and subcu
Good.
fat. We have this collection of really dark black pigment,
Yeah.
and it's surrounded by this foreign body reaction, granulomatous reaction. And because of the color, and it looks like it's just being chewed up by some macrophages, it's really, really dark, so it reminded me of like a carbon tattoo or a traumatic tattoo.
Yeah. So why is it not like the O in Mom or something like that some guy's got tattooed on his arm?
It seems a little bit deeper.
It's very deep, yeah.
And
This would be an
A larger
incompetent
collection.
tattoo artist if you did this.
Yes.
I mean, you'd have like take a cannon and inject a chunk of carbon into the skin if this were a tattoo. Normally, if you look at professional tattoos, even prison tattoos, they're kind of up in this area, pretty superficial. They don't get deep, and they don't get these big giant clumps of carbon. So we call these carbon tattoos. This is really a traumatic tattoo. Okay, so you're right. Well, what else can give you black junk in the skin like this besides carbon?
Rodriguez.
Not really calcium. That's not black. That's purple. But there's a few other things that can give you black that are exogenous. What if it looks like little round drops? Little round drops. It almost looks like it shouldn't even be in the skin, and it's round and black. It doesn't transmit any light. You may not have seen it. You probably are aware that they exist. Elemental mercury.
Huh.
If you get, and what we used to see in the old days were people that had the mercury thermometers. I don't know, do they even make mercury thermometers anymore? Do they even exist in the world? I don't know, but yeah, maybe in India or something like that. But people would like break them sometimes, and the mercury would get implanted in their skin. You see these round aggregations of mercury. They don't look like this, but they're very, very round. Look like, drops. What else can give you a dark black color in the skin? Not these big clumps like this, but black.
Asphalt.
Well, yeah, if there's dirt, but that's carbon that gets put in. Usually it's tar, obviously it's carbon. So what else?
Ochronosis.
That's usually not black, though. It looks black clinically, but histologically, that's golden brown. It's staining the elastic fibers. What else looks black? Small black particles, teensy tiny, that stain elastic fibers around sweat glands. Silver, yeah, silver. That's going to look like some of these little fine granules like there. So this is not silver, but that also can give you a dark color. So somebody that's been taking, argyria, or even traumatic argyria, piercing, so that can give you small black droplets. So there's not too terrible many things like that that give you this exogenous black. Of course, melanin is black. Okay, so that's a carbon tattoo. There's a guy that's got that there. I don't know how you got that. Maybe you got shot or something. It's almost like something that's planted there. So this is probably from a pencil lead. Somebody stabbed their friend with a pencil, or they stabbed themselves. Okay. Yeah, know your pigment colors too, like if you some bile, and so make sure that that's something the boards can easily ask you about too. Okay, this gorgeous example.
So this is a dermatopathy of non-acral skin.
Good.
On examination, I thought that most of the findings were in the dermis, extending into the epidermis, but mostly superficial.
Okay, what's the pattern? This is a beautiful one for low power diagnosis. So you're not going to be able to make the diagnosis for certain. But at low power, you can say, we really have to rule out this disease based on this pattern.
Like an interface pattern, but kind
Well,
of
is it
epidermotropic.
truly interface? Now, interface, remember, it obscures the dermal junction 100%. It's either got holes, vacuolar alterations.
Oh, no, then. It's very different parts, I thought.
Yeah, but you're right. It's got this pattern here, doesn't it? So what do you call this pattern?
Lichen?
It's not purely lichenoid, because that should obscure the junction. It's like a band-like infiltrate, isn't it? Okay, so what do you think about when you see this sort of diffuse band-like infiltrate pretty much hugging the papillary dermis and the upper reticular dermis like this? What are some things you think about at low power? And you're going to confirm it when you go to higher power.
So I thought about lichen planus, that's
It'd be a funny lichen planus, wouldn't it? Because it doesn't have the irregular epidermal hyperplasia, the
No.
hyperkeratosis, hypergranulosis, the real lichen infiltration. It's a different pattern than true lichen planus.
I thought about
Good. That's what I wanted you to say. Excellent. Anything else that you might think about?
I thought about, I mainly went through like an interface differential, so maybe
It's not purely interface,
yeah,
but it's,
I see that, yeah.
So obviously you think about MF or the MF simulators. Possibly a drug reaction, that can look like MF. Photodermatitis, lichenoid, again, it's not purely lichenoid, we call it like a lichenoid photodermatitis. Chronic actinic dermatitis, look exactly like mycosis fungoides clinically and histologically. Sometimes early LSNA can look like this. So then we go to higher magnification, and what are we looking for now?
So in terms of mycosis fungoides,
Yeah.
you're looking at the lymphocytes.
Are you looking at the lymphocytes? Okay, what are you looking for in the lymphocytes?
Well, the
Morphology
size.
or what else?
The size.
You know, I look at that last,
Okay.
especially in patch stage disease. So this would be patch, right?
Okay.
So I want to know where they are.
Yeah, so they tag along.
Yeah, are they hugging the basement membrane zone or the basal layer or the epidermis, sort of in a little kind of coalescent pattern? Also, I want to see if there's thick collagen in the papillary dermis, like here. If there's any eosinophils, does that mean it can't be MF?
No.
Absolutely not. You get eosinophils in MF, you get eosinophilia. Circulating eosinophilia sometimes in patients with mycosis fungoides. Okay, so you see there are cells at the basal cell layer. You got this thick keloidal collagen bundles in the papillary dermis. Why does that develop? Why do you get that?
A reactive process, I suppose, but
Mainly just because it's been there a long time.
okay.
So this is a sign of chronicity. You see this kind of thick fettuccine sign that Dr. Atkins used to call it years ago? That's a sign that it's a chronic process. And we all know that MF is a long-standing disease. So this has been there for years. This didn't happen a week ago. Okay, so it's got the thick collagen bundles. It's got some focal areas with cells in the epidermis. The last thing you do then is look at the size of the lymphocytes. And in a lot of cases in early MF, they're not too atypical. They tend to be larger when they're in the epidermis than when they're in the dermis still, but that, you know, is not 100%. So, yeah, some of these may be slightly cerebriform and atypical, but you see it's pretty subtle atypia. This doesn't look like the atypical lymphocytes of lymphomatoid papulosis, for example, something like that. So this is patch stage, early, quote-unquote, MF. It's really not early. It's been there for many years, but it hasn't progressed to patch plaques, nodules, or tumors. This is kind of what they look like that cigarette paper wrinkling like this. Okay, it's usually the buttock area, waistband area. What is a diagnosis that you never want to use for this entity? At least not in my presence. You don't want to use it.
Parasite?
Yeah, good. Right. You don't want to call it parasoriasis. Why? There's a reason for it. It's not just that we don't like it. You know, we don't want to discriminate against the poor term. But why don't we like parasoriasis? When was it invented? Who first used parasoriasis? Probably some French dermatologist back in the 1800s, you know. And the reason they called it that is because it looked clinically a little bit like psoriasis, but it wasn't psoriasis. So well, let's call it near psoriasis. Let's don't be specific for the diagnosis. Let's give it a crappy name and call it parasoriasis. So it's really what it is patch stage MF. And the other thing that gets called parasoriasis is pityriasis lichenoides, parasoriasis of Juliusberg. So it's not a specific name, so avoid it. You can make the diagnosis of mycosis fungoides in this biopsy, right here, right now, treat patient, and make them well. If you call it parasoriasis, you'll fiddle around with it, you'll take more biopsies, you put them on steroids, it continues, then you're better, eventually get plaques, tumors, and now we can call it enough. So the thing is, you want to be able to diagnose it at this stage, because this is a curable stage. Okay. All right. Who wants to do this one?
Yeah,
If it shows there, it's online, right? Okay. All right. Who wants to give this one a go?
Alright, so we have a punch biopsy here. The action is in the deep dermis, sub-Q
Good.
fat. Yeah, dermis and dermis look relatively normal. Didn't think this was true paniculitis. It's mostly that inflammation that's focusing on that large vessel there.
Okay.
So I saw this inflammation, it's kind of going back and forth between the vasculitis and vasculopathy. I think this is more of a vasculopathy because it looks like there's a clot in the vessel there.
Now, vasculopathy, that's not a very good term either, but basically, generally, you get inflammation, as much inflammation in so-called vasculopathy versus...
Yeah, I guess you shouldn't just
Yeah,
run
this
inside
one's got
the vessel.
inflammation in the wall of blood vessel. And this is a relatively large blood vessel. It's not a capillary, so it's a larger vessel. And if you talk to Warren Piet, he says the skin doesn't have large blood vessels. It's like they think it does, but it doesn't. So this is about as big as the blood vessels get in the skin. But when you get inflammatory cells in a blood vessel like this, it's got a fairly large, thick wall to it, like an arteriole like this. It's by definition vasculitis. Now you do have fibrin in here. You do have fibrin, so a higher power, this kind of goes a little off. Is that what you're saying here? So fibrin. So you got a relatively large blood vessel with vasculitis. What's the likely diagnosis here?
So the medium to large vessel vasculitis, so Wegener's, Church-Strauss, PAN.
Wegener and Church-Strauss, what do you usually see in the larger vessels of that condition? Wegener's especially. What kind of cells are in the infiltrate?
Or neutrophils?
Good try.
Well, Church-Strauss you see EOs.
Yeah, and you also see histiocytes. So granulomatous vasculitis. Think of Wegener's and Church-Strauss. A lot of people think Church-Strauss and Wegener are kind of maybe related to one another. So you kind of lump those together a little bit. So I like your other idea of PAN. And so there is some fat involvement, and you're right. This is a disease that has two identities. It can either be considered vasculitis with some paniculitis, or it can be paniculitis with vasculitis. And it usually gives you mostly just inflammation of the blood vessel, relatively limited inflammation of the fat. So PAN is the most likely diagnosis in this case.
What about erythema induratum?
Okay, you tell me why that's not a real good answer for this specific case.
Because it's an artery instead of vein, probably?
No.
Because there are no neutrophils?
Sort of. You're getting closer. In general, erythema induratum, you get vasculitis with marked necrosis, lobular paniculitis,
Okay.
tons of paniculitis. It's an interesting question as to why you get a pretty large blood vessel involved and fat sort of slowly spared. Whereas in erythema induratum, you get similar sized blood vessel, maybe even smaller vessels, with tons of inflammation of the fat. I'm not sure that knows the answer to that. We do know that they're both kind of immune complex mediated processes, but I don't know why this one can pretty much trash a blood vessel and leave fat alone. Same thing is true with thrombophlebitis. You can get lots of inflammation of the vein with minimal inflammation of the fat. So it's a good question, and I don't know the answer, but generally erythema induratum is lots of inflammation. They ulcerate, oily stuff comes out of the skin. Clinically, you may see overlying liver-reticularis-like pattern. That's a good sign. When you see that pattern and there's vasculitis, it usually means it's a larger blood vessel involved when you get that liver-reticularis pattern. But clinically, this may just feel like a lump, a nodule. You're going to see anything. Now, there's two types of polyarteritis nodosa histologically, right?
The acute and chronic type.
Well, anything can be acute and chronic, but there's the so-called sort of larger blood vessel type like this, and then there's the microscopic polyangiitis, which is a crappy name. But you can get multiple small vessel LCD, and you can get this larger blood vessel involved. The larger blood vessel, paradoxically, tends not to involve systemic organs. The small vessel vasculitis is kidney disease a lot of times. You get modernized multiplex. You get all sorts of things with the small vessel, so-called polyangiitis, which I don't like that term very much. But anyway, so this is PAN. Nice example. Everybody got it? Presumably?
Yeah, I have 3 differences.
Okay.
Including. That's,
All right, who wants to give this one a go?
Alright, this one is biopsy where we see some acanthosis and remains of dermis with this pink color. Yeah,
It's got this sort of
amorphous
pinkish.
substance.
Okay, good. So you picked up on that. So what are we dealing with here?
But the position.
A deposit.
Yeah.
Good. A deposit.
Yeah,
So what do you think happened here?
I think either the skin broke. I mean, I saw it and I thought of gout, and I thought it could have been like a tophi or something that
Yeah,
broke. And
that's exactly what it is. It's a gouty tophus. So the way this works is the uric acid gets deposited. Okay, it comes in, it just deposits. It's too concentrates too high in the blood, so it decides to just dump itself out here. Then you get a secondary inflammatory reaction with histiocytes and some plasma cells, and you get what looks almost like palisaded granulomatous dermatitis. So it's a secondary inflammatory reaction. It's not a primary inflammatory process. And then, what does it do at the very end? What's going on over here?
it's escaping.
Yeah, it's trying to be transepidermally eliminated. So what part of the body do you think this might be?
This could be elbows, or this could be.
Possibly, yeah, good. Yeah, it could be the elbow. What's another location that's commonly where gouty tophi occur in the skin?
You can have them in
The
the
toe, but
hands,
not.
or-
But that's different. The toe is the joint space.
Yeah.
This would not be the toe. That's podagra. That's gouty arthritis. Different animal. This is a gouty tophus in the skin. So elbow, knee, but there's one other place, ears. And usually it's thought to be chondro, a roulat basal cell, and that's what this came in as. They didn't think this was gout. And they biopsied, took a shaved biopsy, and lo and behold, they got a gouty tophus. So these don't fit. These are not the right clinical. The right clinical would be a little papule on the ear. And it's got a white kind of cheesy material that's kind of coming out of there, and they think maybe the cartilage is degenerating. It turns out to be a gouty tophus. Now, is there anything in the differentials? So you're on the board exam.
They probably could put amyloid.
Yeah, they put
because
amyloid.
It's pink, but you probably don't see the wisps.
Good, 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 good. Excellent. You don't see wispy in gout in amyloid. That's exactly right.
And
Lipoid proteinosis. Would that look like this?
No.
No, no wispy, nothing like that. So they might put some, like focal cutaneous mucinosis.
Mm-hmm.
You put any kind of things like that on there, so just make sure you recognize that. What if you if you polarize this, positive or negative?
That's negative.
Good, negative. If you wanted to see the crystals, you got to preserve it in 100% alcohol.
Mm-hmm.
And then it kind of looks brown. It doesn't really look kind of pinkish like that. Okay. All right. Very large lesion, right?
Yeah, it was kind of difficult to maneuver with my mouse. This is a pretty large kind of punch. See, I couldn't tell if it was like punch biopsy versus like
If this is a
excision.
punch, it's like Arnold Schwarzenegger.
It wasn't
It would have to be an 8-millimeter giant punch. No girly man doing this.
I just thought the top part looked like a punch. It was like perfectly symmetrical. But yeah, it was an excision.
Yeah, it's probably an incisional biopsy. And what part of the body are we on?
So pretty thin skin, and there's also terminal hairs here, so
Yeah.
it's in the scalp.
Good. And where is the pathology this time?
Deep down and like past the subcutaneous.
Yeah. And what's that called when you're beneath the subcutaneous fat?
The fascia.
Yeah, you're in the fascia. So we're not even in dermatology anymore now. We're in the world of soft tissue neoplasia, right? Okay. So is it benign or malignant?
So benign. No, I guess malignant.
We don't like guesses. I mean, we like an application of criteria. So it's pretty big. We don't know how big, but it's relatively large based on what we have here. I mean, it's compared to most soft tissue neoplasm, which are sometimes the size of softballs or bigger, it's probably not that big. So the criteria changed a little bit in the soft tissue neoplasia. What kind of differentiation are we dealing with here?
So see spindles like
Yeah, spindle cell, good. So we know that there's several different types of spindle cells. Here we've got, what is this stuff here?
So this is like the mixoid kind of loose.
Good, mixoid. Looks just like that hyaluronic acid we saw on the first slide, doesn't it? So it's fibromucinous. Lots of cells that are spindle in shape. There's edema. There's inflammatory cells. There's mucin. So what did you think was going on here?
This was a nodular fasciitis.
Yeah. Now is that benign or malignant?
Benign.
Yeah. It's a benign reactive process. There's a mitotic figure. Are we going to change the diagnosis? No, we're not. Absolutely we're not. This is a stellar biopsy for this. I mean, it's really rare to get this kind of biopsy. And I guess if the derm did this, it's probably like a derm surgeon or something. Because it's really a deep incisional biopsy. And this, what's the other name for this entity? Anybody know? Pseudosarcomatous fasciitis. Because it can simulate a sarcoma. I mean, I've seen these overcalled as sarcomas. You have to be careful. Anytime dermatology and soft tissue neoplasia intersect, there's often a wreck. It's often a problem. So you have to be careful when you're dealing with soft tissue as a dermatologist. What's the pathophysiology of this? Why does it happen?
So it can either be trauma induced.
Yeah, trauma. So if you're a little kid and you fall down and bump your head and you get a knot and you biopsy the knot, this is what it looks like. This is what a knot on your forehead looks like. It's basically just a proliferation of fibroblasts with mucin, and it's just a benign process that usually goes away in a couple of days. So this is on the scalp, so somebody probably got hit on the head with something. And this is kind of what it looks like. That's what it looks like if you cut into it at the growth table. So totally benign process, nothing to worry about. You probably won't get that on the boards, but still, it's worth seeing. Okay, who wants to give this one a go?
So
Beautiful.
this is a punch biopsy, and it looks like it's on the scalp again. Is it, well, it's kind of like terminal hairs. Like they hairs go down to this subq.
Good. It is on the
Um,
scalp.
And then I see an inflammatory process,
Good.
both superficial, like kind of almost band-like, and then a little bit
But it's not the
deeper.
same as the EMF case, is it? You see it's like
No.
around these blood vessels, here, here,
Might
here,
be perivascular
around the follicle a little bit.
Mm-hmm.
What's the pattern of the epidermis?
There's like a little bit of acanthosis.
Yeah, there's definitely a little bit of acanthosis, kind of psoriasiform.
Mm-hmm.
Not as much as we see in classic psoriasis, but definitely it's psoriasiform. And what about the cornified layer?
Let's see. There's some para.
Yeah, parakeratosis. And where is the parakeratosis located?
Within the corner.
So here's a little hair follicle, and here's the infundibulum of the follicle, and we have a mound of parakeratosis sitting over here.
So
and
kind
another
of
little
adjacent
mound
to
of
the
par-
hair
what-
follicle.
Yeah, it's like at the edges of the follicular ostium, at the shoulders of the follicular ostium bilaterally right there. Okay, and then it's also near this hair follicle also. It's present in between the follicles, but not to the same degree as here. So what disease does that?
So I feel like you're leading me down a certain path. This is
Yes,
not the path
very
I was
much
going
so.
down.
Which path are we going down?
Kind of like something, if you're saying more like psoriasiform, like maybe a SIBO psoriasis.
How about just regular old garden variety seborrheic dermatitis?
Could be
Yeah,
normal.
it is that. Here's another, look at this
Seborrheic
one.
dermatitis.
This is gorgeous, how you get the neutrophils and the parakeratosis just at the edges of the follicular osteolyte. That's classic for seborrheic dermatitis. Crusty, oily, ugly scale on the guy's face or scalp or whatever. So this is sebderm. Beautiful example of it. Here you go.
Is it normal to have the inflammation go as, I mean, it's not super deep in this one, but I think that
Yeah,
was
it
throwing
can.
me
It
off
can kind
a
of track
little bit.
down follicles. Yeah, it's like superficially mid. Yeah, you
Okay.
can get a relatively brisk inflammatory reaction sometimes in sebderm. That's why, you want to give them anti-inflammatories sometimes, steroids and whatever, and it works beautifully for it. So seborrheic dermatitis. Sometimes it may be difficult to distinguish from psoriasis, so sometimes it gets called sebopsoriasis because it's got a lot more psoriasis hyperplasia than this and maybe more diffuse parakeratosis. That's more just kind of a name that we use sometimes, but this really looks fantastic for sebderm this time. Everybody got it? Good. No problem. Okay. This one's very nice also.
So here we have a punch biopsy, non-equal skin. What stands out is this kind of collection of paler staining cells,
Good.
dermis, and kind of nodular aggregates, or kind of just diffuse, I'd say, really, in the superficial dermis. And it's ulcerated as well.
Yeah, it's got a lot of crusting up there, doesn't
Crusting.
it?
Mm-hmm. So I'd like to go closer and look at the cell type.
What kind of cells did you think these were?
I thought maybe they were newts, kind of from low power because of the paler staining.
Well, some of them are newts,
and
aren't
some of
they?
them are newts, yeah.
These are.
Mm-hmm. But now that I'm looking a little closer, some of them have a little bit larger nuclei.
Yeah,
They're-
lots of cytoplasm.
Lots of
Pale, as
cytoplasm.
you noticed, at low power.
Mm-hmm. And some of them have this kind of kidney bean shaped nuclei, reniform nuclei.
Yeah, some of them do, like that one does.
Mm-hmm.
Some of them don't look too kidneyoid. They look
Yeah.
sort of ugly and very atypical,
Yeah,
like
and
over here.
that's what kind of threw me off. 'Cause I was thinking like Langerhans cells, but are those
Do all Langerhans cells have kidney bean nuclei and look perfectly like little kidneys?
No.
No, they don't. And especially if they've got the real malignant variant of Langerhans cell
They can be pretty
histocytosis.
atypical.
Yeah. They're also eosinophils. That
Mhm.
helps.
Yes.
So yeah, this is an example of Langerhans cell histocytosis. Now one thing about this, clinically, there's often a lot of crusting. And I've seen cases where the crust and the inflammation is so intense you don't even see the Langerhans cell, so you have to be aware of that. There's several different forms. These are a couple of examples I've seen in childhood. You can also see this in adults. So it can be intertriginous, like eminexilla and groin area adults. So you basically have to beware of this in people that have what looks like a diaper dermatitis or chronic intertrigo in an adult and it doesn't respond to therapy. Think about Langerhans cell histocytosis. Here's the stain for CD1A, which is a very, very strong staining pattern here. Okay. Everybody got that one too?
Yeah.
Good. Okay.
Okay, so this is a shape biopsy. The changes are mostly seen right at the derm-epidermal junction.
Yeah. And maybe in the epidermis too.
Yeah.
So what is the general, is it benign or malignant?
Benign.
Good. Seems to be fairly small, fairly symmetrical, mostly nested. What type of differentiation are we looking at here?
I thought that they're a little spindle, but I think melanocytes.
Melanocytes. Good. So you have melanocytic differentiation. Okay. And you said you saw the cells look somewhat spindle. Do they look anything else other than spindle?
Well, they're in these lovely nests.
Yeah.
with
Lovely nest. I like
Yeah,
it. So,
they're
yeah.
neat, right? With little clefts around the nest.
Yeah.
And there was some pigment. I thought it was pretty classic for spits, but then I wasn't sure if they were maybe tricking us with something.
No, we never would trick you out. Absolutely not.
But I couldn't see much else. Like I didn't see anything else that worried me.
Good. So this is a nice classic example of the Spitz's nevus. Now you can get mitotic figures in Spitz's nevi, so don't let that fool you. But this does have virtually every feature for Spitz's nevus: elongated nest, spindle epithelioid cells, clefts, growing epidermal hyperplasia. You may see some dull pink globules in the lesion.
It's a cleaner body.
Yeah, I don't know if we had too
Yeah, I
many
didn't-
in this one.
Yeah, I didn't see any obvious ones.
Yeah, you don't have to have them. If they're present, it's great, but you don't have to have them. There might be an occasional one or two. Here we go. There's some right there. Dull pink globules, see them right there?
Mm-hmm.
They can sometimes be pigmented too. So this is a nice example of the Spitz's nevus. Would we remove this?
No.
What if it's a 50-year-old?
No. Well, maybe if it was there.
You don't
I
have
don't
to.
know.
I mean, a lot of times we do, but basically you don't have to, especially if it's a classic situation like this in a child. I mean, these are not of any concern for melanoma here, and you don't want to do fish on this because it might come back as positive. You don't want to do genes on it. Just leave it alone. Start studying it, negative things happen. So that's what Spitz means. There are other things in the differential that you should just look at on your, sometimes xanthogranuloma.
Alright, so we have punch biopsy, kind of squared off punch here. Relatively shallow, but some larger hairs, so I was also thinking maybe on the scalp.
Good. Yeah. Alopecia possibly then, right?
Alopecia,
Okay, so inflammatory or non-inflammatory alopecia?
I think that probably was inflammatory. There's a little bit of inflammation.
Yeah,
Yeah,
there's
right
still
there.
some right here. Good.
Right
And then
there.
where is the inflammation located?
Pretty much directly around the hair follicle, and both of those kind of tracks, like below it.
Yeah, it's just like a rifle shot right at these follicles. Good. And notice which part of the follicle seems to be affected.
Right at the bulb.
Yeah, good. What's the diagnosis? You
So with
said everything you
these,
need to know to make the diagnosis.
So with these fibrous tracks, I was thinking like LPP.
Good, perfect. Lichen planopilaris. Now, what's the histologic identical twin of LPP? And it probably is a variant of LPP.
There's the like frontal fibrosing.
Yes, excellent. Frontal fibrosing alopecia, which is probably a variant of LPP. See the frontal areas of the scalp. The patients we've seen seem to be women more commonly. This kind of redness there that sort of sticks around. This is a permanent scarring alopecia. Okay. Any new drugs for this disease? I just heard it at the AAD meeting a couple of weeks ago. Naltrexone, 3 milligrams a day for this and lichen planopilaris. Sometimes works. So you have to compound it because the naltrexone tablets come 50 milligrams. But actually, there's some data, papers published that suggests that it may be effective in this condition. So something to think about. Next patient you get with this or LPP, think about using naltrexone. We're starting to visit some of our patients there.
Well, hey, low dose Lasix.
Works for that too?
Yeah.
I'm not sure how well it works for this stuff, by the way.
I don't know either.
It's worth a try, because nothing else works except for
Yeah,
illegal
that's it.
steroid. Okay, this is
Alright.
another fantastic
Punch
one that's
biopsy.
doable at low power.
Yeah, so the striking thing about this punch biopsy is there's some edema, striking edema at the dermoepidermal junction pretty much, and then there's this like broad infiltrate diffuse in the higher dermis with some.
Yeah, so it's kind of a dense diffuse infiltrate.
Yeah.
What kind of cells are these?
So there are some lymphocytes for sure.
What are the main types of cells?
There are like a mix of cells. There are neutrophils.
Yes, there's tons of polys here.
Yeah.
even as power, you can say, well, you know, these aren't solid jet black lesions like you see with lymphocytes. These kind of little, almost kind of salt and pepper kind of morphology. So when you see that, you say these are probably going to be neutrophils. Then you got a higher magnification, and of course, there's tons of polys. There may be some EOs in here too.
Yeah, I saw many EOs, and that threw me to two different places. But
Okay, it should make you kind of pull back on it a little bit. But what if there were no EOs? What's the most likely diagnosis?
probably sweets.
Sweets. With this pattern, this dense diffuse
Yeah.
infiltrate with papillary edema, sweets. If there are EOs, it still can be sweets.
Yes.
You see EOs and sweets sometimes, so don't let that just totally throw you off. You can get some nuclear dust in sweets also, so don't let that throw you off either. So this was sweets. Now what other items are in the differential diagnosis here?
So with all these EOs, I thought maybe a drug reaction,
Okay,
and
it's
then
not a bad idea. It'd have to be a sweets-like drug
Yeah.
reaction, but
Which
it
is-
could be.
yeah, and then the other thing, when I saw the edema and so many EOs, I didn't see other signs, but I thought PMLE, that was like a kind of like flash moment. Oh, okay, but I didn't see like changes in the epidermis.
Yeah, it's
To-
not.
to
That's
go
not
with-
really good for PMLE
Yeah.
either, is it? That's usually superficial deep lymphocytic infiltrate with
Mhm.
papillary edema. It's not really dense diffuse like this.
Yeah.
So that's. But the only thing that's similar to PMLE is papillary edema. So don't let
Yeah.
one feature.
Yeah, that's why I threw that out, and I started thinking, well, maybe this is a drug reaction with all these EOs. But anyway,
You can get drug reactions with no EOs too, by the way. So don't let that
that
throw
is
you.
true.
But other items of the differential diagnosis, the other neutrophilic dermatoses, papillary gangrenosum,
Mm-hmm.
bowel-associated dermatosis arthritis syndrome, you know, those kind of things. Behçet's. So remember the other neutrophilic dermatoses here. Okay. This one keeps going out of focus. I think this keeps moving.
And they would share the neutrophilic infiltrate, but would they share also these high papillary edema?
Usually not. That's
Okay.
why you would favor sweets.
Okay.
Yes. Okay. It's possible. Now, it'd have to be a really bizarre bite, but it could. Sometimes maybe cellulitis could possibly do it too. Maybe. Okay, let's give this one a go.
Well, so here we're looking at a shave biopsy and reactions in the dermis. So we see these kind of dark purple collections from far, like from this magnification. They look, you know, varying sizes. It can't tell from here.
So what is this stuff? We've seen gout today. We've seen carbon today.
This might have been calcium.
Calcium today. Yeah. What color is this?
Purple.
Purple. Deep, dark purple.
So calcinosis cutis.
Calcinosis cutis. Now there's several different settings where you can get calcinosis cutis. What if this came in as a solitary papule on the eyelid of a 5-year-old kid? Anybody know?
Like a calcified pilometricoma or something like that? Or you're
Well,
looking
that
for-
would, but that wouldn't. You see the features of pilometricoma.
Yeah.
There's a thing called a subepidermal calcified nodule.
Oh yeah, that's on the chin too.
Yeah, solitary papule, often in children. There are other settings where you get calcinosis cutis. What are some other situations where you get calcinosis cutis?
Scrotal calciphylaxis.
Scrotal calcinosis, calciphylaxis is one. Juvenile dermatomyositis, crest, right? So a lot of situations where you can get calcinosis. You get calcification in tumors like pilometricoma, calcifying epithelioma of Malherbe, calcification in basal cells sometimes, calcification in breast cancer. So you get lots of calcification can occur in neoplasms. So good to recognize that as basically calcium. Now, what happens if you leave calcium in the skin alone a long time? What can happen to it?
Can it be extravasated?
It can also turn into bone eventually.
Osteophyte.
Where's the I think it's not on this slide. Ah, there it is. Okay, good. This is good. This piece is good.
I'll have it the whole.
So if you leave it in there, yeah, this is cool kind of because it did. What happened here? What's this little thing?
Cup shape where the calcium was.
Yeah, this used to be here. And then when they did the sectioning, it probably just chunked it out and it stayed on the slide. And here it is. So if you leave calcium in the skin long enough, what can happen to it?
There it's turned into bone.
It can form into bone.
Ossified, yeah.
Yeah, you can form bone. So this is osteoma cutis. And what's the most common setting where you see osteoma
Trauma.
cutis?
Acne scars.
Yeah, acne scars. These little papules, and usually it doesn't look like that. Usually little small papules are kind of purplish. When you take them, they feel like you're getting grit out of the skin. Take a little curette and just kind of cure them out. And then if you look in the center of osteoma cutis, what do you often see? Yeah, bone marrow. You can get little incipient bone marrow that can form. There have actually been case reports of diagnosing patients' leukemia in the little bone marrow, their osteoma cutis sometimes. It happens rarely. So there's probably a little incipient bone marrow that's formed in a couple areas, those little neutrophils and maybe nucleated red blood cells. So anyway, it's an interesting little benign process, osteoma cutis. Okay, everybody got that one right too?
No, I was a little off with the. I didn't check the bone on the side, and I was like, "What the hell is that
Yeah.
part missing?
It's just
Did they cut it on purpose?" What the
Yeah, we wouldn't be that diabolical. So yeah, osteoma cutis. Okay, any questions about anything?
No.
Okay, very good.
Thank you very much.
Thank
You're welcome. You're welcome. Since we're moving around, every time I hit it, it kind of gradually moves and